आगे। हेलो। हेलो। टेस्टिंग। हेलो टेस्टिंग।
हेलो। हेलो टेस्टिंग। एक दो तीन चार कैमरा काटो ये या तो ऑटोमेटिकली करना। साड़ी को बड़े मुश्किल से आती है फोन वाला रेडियो स्टेशन फोन लग रही है। ये वही बताएगा इसके बाद बहुत सारे वहां पे भी इसने किया होगा एक बार ना
Ask any questions? Yeah, right.
Hi, sir.
Only problem is my site is not that good. You have to read out the question. I can't. Okay. Fine, but that will be at the end. We can figure out something. Can we start?
Hello. Hello. Testing. Hello.
Good evening, everyone. We are about to start the program. And are you able to hear us? Are we audible here? You can just message in the chat box. Are we audible? Audible. Okay.
Well, we are about to begin our breast cancer contouring workshop, which is the first of its kind in J&K, being organized at American Oncology Institute by American Oncology Institute. And we are thankful to Professor Dr. Sushil Beriwal, sir, who is Vice President Varian and academic head of our institute, who is joining us live from US. We are thankful to Dr. M. Sunita, who has come all the way from Hyderabad to give hands-on training to postgraduate and registrars on contouring, breast cancer contouring. And we are also thankful to Vibhor Gupta, sir, who has come all the way from Hyderabad to give us blessings. Dr. Neeraj Bishnoi, sir, who has been always kind to us, who is our main support. And Dr. Rajiv Kundra, sir, who is here only. And a special thank to our facility director, Rehan, sir, who has provided all the logistics. Me, along with Dr. Jagmohan Singh, who is course coordinator, and Dr. Sumit Pandita, who is course coordinator, welcome you all. And a special thanks to all of those who has joined us live from via the link. I am seeing Dr. Rahul Sharma right there. He is advisor to our trust and has been always ahead with us in our academic agenda right from the word go when we started in 2015 in Crabecons. Welcome to Crabecon 2023, the 10th Crabecon, where we are going to start with breast cancer contouring workshop. And I hand it over to Madam M. Sunita to start the proceedings and start with the contouring workshop. Thank you, ma'am.
Actually, we thought like we'll ask Dr. Beriwal to do his first presentation. Sir is a little bit occupied. By the time he logs in, I'll start off with a little bit of presentation from my side. And after that, once Sir logs in, I will hand it over to him. Then, yeah.
I'm sorry to disturb you in
Yeah,
between.
yeah.
We welcome Dr. Neeraj Jain, Professor and Head from SGRD Shri Guru Ramdas Hospital, Amritsar, the President of our North Zone Association of Radiation Oncologists of India, and our guest of honor. Please, sir, take seat so that we can start the proceedings. Thank you, sir.
Can you see the slides? So breast cancer contouring is such a big challenge, although we have been treating this since ages. It was all based on 2D techniques, based on bony landmarks. But recently we see that there are a lot of changes, lot of new guidelines have come. But let me tell you, honestly, all these guidelines are not based on any randomized clinical trials, and they are all expert opinions, whether it is RTOG, ESTRO, or PROCAP guidelines, or anyone. Okay, So any case has to be based on case-to-case selection, and it is always a physician choice because you are the primary physician and you know the very well about what was the initial stage of this patient, and then how what was the initial sites of nodal presentation, everything, and based on that only you have to take a call. Can we show the slides? It is visible? Yeah. Okay. So we have moved on from the bony landmarks, as I said, and it is only based on the vascular landmarks what we do right now. And this is very important because if you follow the guidelines on bony landmarks, like those RTOG guidelines, you will be treating lot of normal tissues. There'll be lot of side effects to the patient, and also the landmarks will not be constant throughout the treatment. I mean, as and when the patient's position changes, the volumes also will change. And these are inconsistent things. So it's always better to learn the vascular anatomy. And we know that nodes will be always distributed around the veins. So around 5 mm margin around the veins, we have the nodal lymphatics. So in this presentation, we'll just see a little bit of anatomy. Then we'll talk about the indications, where to give IMNRT, all those things. And then we'll see how to draw the regional nodes. This I have kept it first because this is more important and more challenging most of the times, because chest wall and BCS is something very simple. You do the wire marking around the breast, whatever you see, we'll talk about it later. So vascular anatomy, as I said, there are very few veins and vessels which we need to learn. So first thing is, we'll start off with the venous system. So we have the left brachiocephalic vein here. How is this formed? This is formed by the fusion of the subclavian vein and also the internal jugular vein. The internal jugular vein, it drains the head and neck area, and the subclavian vein, it drains the upper limb. So these two will form the brachiocephalic vein, and this left brachiocephalic vein will cross to the opposite side to unite with the right brachiocephalic vein to form the superior vena cava. So this is more than enough. And the rest of the things, if you are interested, you can learn. But for breast cancer contouring, I'll be speaking little bit in bits and pieces. If I start talking entirely about the anatomy, this half an hour will not be sufficient for us to complete everything. Okay, so it is left brachiocephalic, right brachiocephalic, both of them uniting to form the superior vena cava, and that will drain into the atrium. Then we have the arteries. So we have arteries which are basically the left subclavian artery, the left common carotid artery, and the brachiocephalic trunk on the right side, which divides into right common carotid artery and right subclavian artery. All these vessels arise from the arch of aorta. And these two, since they are directly, very close to the left side of the body, they come directly from the heart. For the right side, it is a little bit away from the body. So they will have a bridge in the form of brachiocephalic artery, which again divides into subclavian artery, which supplies the arm, and the common carotid artery, which supplies the head and neck area. So that's about the arteries. So now we have to understand what is the relation of the artery with the vein. Okay, so artery is always superior and posterior to the vein. So this is the subclavian vessel, the subclavian vein, and the subclavian artery, which will arch over the apex of the lung and then continues to form the axillary vessels, right? So this is about the relation of the arteries and veins in the neck. So if you see this vein, why I'm stressing in these arteries and veins is that all the ISRO guidelines are based on vessels only. And if you see, this is the anterior scalene muscle, and at the insertion, this scalene muscle goes and inserts into the first rib, And at the insertion, you find that the muscle is between the vein and the artery. So this is very important because initially I used to think why ISTRO guidelines has included, the scalene muscle in the level 4 lymphatics, level 4 contouring. The reason is that the vein is very closely attached to the muscle insertion. So that is the reason we need to understand this relation. And then we have the internal mammary artery, which is arising from the subclavian, first part of the subclavian vein, and that runs along the medial side of the body, parasternal area. Then few words about the muscles. This is a pectoral muscle, minor pectoral muscle arising from third, fourth, and fifth rib, inserting into the coracoid process. Then we have the pectoralis major muscle, which arises from the clavicle and the sternum and goes and inserts into the humerus. Then we have the latissimus dorsi arising from the back and going into the humerus. Serratus anterior again arising from the ribs and going and inserting into the scapula. Then anterior scalene muscle, which arises from the cervical vertebra, that is third, fourth, and fifth cervical vertebra, and goes and inserts into the first rib. So sir has joined up. 2 minutes, sir. I'll hand it over to you. And so the insertion is very important here. As the scalene muscle gets inserted into
Dr.
the first
Sunita.
rib. Yes, sir.
You can complete your anatomical section. That is good. then.
Yeah. So just one more section, one more slice. So as it goes and inserts into the first rib, it goes in between the artery and vein. So this is how we, and after sir's presentation, I'll show you on a real time, CT scans, how to identify these
No,
veins.
go ahead and continue and do the CT scan part for continuity, because I can do after this one.
Right. Can we open the Citrix? Come out of the
Yeah.
slides.
And for the participants
Exit
who
the
are online,
slides.
for the participants who are online, feel free to put your question in chat or after every present, so we can answer the questions. Those who are in on live, they can ask the question live, but the other ones can put question in the chat. It's important to ask question to make it interactive.
Okay. Yeah. So I'll switch off everything. It's so intimidating in the beginning to understand which is the artery and which is the vein. So I've done some prior homework to show you what are all the arteries. Okay. So this is the arch of aorta. This is the arch of aorta. From here, we see as we go up, we see 3 vessels which are arising from the arch of aorta. This is the left subclavian artery, then left common carotid artery, and the right brachiocephalic trunk, which divides into the right common carotid artery and right subclavian artery as we go up. So here we see there is a division. Now the right common carotid artery is separated and the right subclavian artery has come out. And as it goes and arches over the apex of the lung. Sometimes it might not be very clearly visible because of the partial volume effect, and maybe in that slice you don't see the vein vessel properly. But by and large, by moving the slices above and below, we can easily find out. So I'll show you again. These are the 3 vessels. Okay, this is the subclavian artery on the left side, the common carotid artery for the left side. As we go above, we see the right side brachiocephalic trunk, which goes and divides into the subclavian artery and the common carotid artery on the right side. This will cross the first rib to form the axillary artery. So the subclavian artery has three parts. This is the scalene muscle. I'll switch on the scalene muscle here. So this scalene muscle will divide the subclavian artery into three parts: first part, second part, and third part. So from the first part, we have you can see this is the small wart-like structure, and that is the internal mammary artery. So this small wart-like structure which projects into the heart, I mean the lung, is the internal mammary artery. I'll show you while doing the contouring of that internal mammary vein. Then let me show you the veins. Where is the vein? I am in. Yeah. We'll see the venous system now. So for this, we have to trace from the top. I've drawn on the right side. This is the internal jugular vein. As we go down, it goes and unites with the subclavian vein to form this is the subclavian vein, which is arching over the apex of the lung, and this unites to form the brachiocephalic trunk. So the internal jugular vein, which is coming from the top, it unites with this subclavian vein to form the brachiocephalic trunk, and then that goes and drains into the superior vena cava. And you see the subclavian vein on the left side, has a bigger course. Okay, the brachiocephalic trunk, which arises from combination of the subclavian vein on the left side with the internal jugular vein, forms the brachiocephalic trunk, which crosses to the opposite side, and then this unites into the superior vena cava. So this is the anatomy of the vessels. Okay. So, sir, if you want to continue from here, maybe after this we can show the contouring of the lymph nodes. Is that okay? You're not audible, sir. You're not audible.
Okay, sounds good. I need to
Yeah.
see if I can share. Let me see if I can take control.
Sir wants to share.
So you have to unshare so I can get to share.
Allow.
Sir, you are able to control now?
No, I don't see this share button. The share button is
Okay. I am unsharing. After that, you can share.
okay. Got it. Okay. So what I'm going to talk about, I'll focus more on the prescription and the quality aspect of it. And then after that, Dr. Sunita would show you the live contouring. So, you know, like the prescription has for radiation oncology has changed. And I always say it is not one size fit model anymore. When I graduated, everybody used to get 6 weeks of radiation. Now the course of radiation therapy can vary from no radiation to 1 week, to 2 weeks, to 3 weeks, to 5 weeks, to 6 weeks. So you have to customize the dose of radiation or prescription of radiation based on the individual situation. So I'll discuss some aspect of it, but let me see. The sharing is still not. And for people who are in the audience, they can feel free to ask the question to make it interactive. And for people in the chat, do question, because what I'm going to present is not necessarily the practice pattern for all. And it is not the only way for people to practice. So I just want to have audience to have a good understanding of what to do in different scenario. And I will also highlight some of the contouring controversies, but I will have Dr. Sunita show the contouring for sure. So it's still the share is still not visible.
Can check now?
Yes, now it is okay. Good.
Okay, thank you.
Okay. Can people see the slides?
Yeah.
Okay, good. So, yeah, like, I'll start with with a simple case like scenario and then go from there. Not letting me. I can't change the slide.
Let me try from my side.
Sir, I think you are sharing the entire control is with you.
Yeah, but like when I'm trying to. Yeah, now it is okay. Okay. So what I will try to discuss is early stage breast cancer, advanced stage breast cancer with regional node, just to highlight some technique part of it. I would not focus as much on contouring because Dr. Sunita will do that. I may highlight some controversial as well. I'll more focus on the dosimetric part of it and the prescription. So, this is a typical early stage breast cancer. 55-year-old postmenopausal women found to have suspicious lesion in the lower inner quadrant. The biopsy shows ER/PR positive, HER2 negative, intermediate grade disease. For the people who are in the audience, if they have mic, like what kind of surgery would they do for this patient? If she opts for breast conserving therapy, what kind of surgery would be done?
Audio is disabled for everyone, sir.
No, even for
Down in
the.
chat box.
They can put it in the chat box.
Okay, got it. Yeah, then it will be less interactive. So, the typical left partial mastectomy and send it for biopsy, 2 centimeter disease, negative margins, negative node. Out here, we do genomic profiling. It could be oncotype or MammaPrint. And if it is low, they don't get chemotherapy. So oncotype
Sir,
or
Sir,
MammaPrint is
we have mic here. So for the students who are present here, they can answer. You can be
Okay, got it.
interactive. Yeah.
Okay, got it. Now, this patient has left partial mastectomy and sent it for biopsy done. The oncotype is low. So patient will get anti-estrogen therapy and the patient comes to you as a radiation oncologist. So for people in the audience, like what would you, like what technique would you prescribe? What dose would you prescribe? And how would you treat this patient? Any one of you? Just speak up.
Can
I
you
mean,
summarize the case? Can you
this is a
summarize the
simple-
case once?
This is simple stage 1 breast cancer, post breast conserving therapy with negative nodes, with low oncotype DX. So patient will not get chemotherapy, will only get anti-estrogen therapy. And patient now has been sent to you for radiation consultation. So tell me, what would you do? Anybody in the audience? Just this is simple, straightforward, not a complicated question. And so this is the bread and butter of what we do as radiation oncologists.
So
Speak up,
basically, this is a T1 M0 post mastectomy case. Would you like to give radiation?
No,
Huh?
not mastectomy, lumpectomy. Am I not
Acha, then
audible?
you have,
Yes, sir.
you're audible, but the
Yeah,
slide
yeah.
shows a mastectomy there.
No, it
That's
says
the reason.
partial mastectomy. That's the word used sometime for lumpectomy.
Okay, right.
Yeah, so in the audience, patient had lumpectomy done with center for biopsy. Would you give, first of all, give mic to any of the student? Let me ask him directly.
Or we'll start from the beginning. No, nobody is volunteering. Yeah.
This is the phase of learning.
Yes.
Yeah, would you give radiation therapy or not?
Yes, so we'll give radiation therapy because we have initially done the BCS of the patient. So according to that, we have to go for the RT to the patient.
Got it. Okay. And what would you quote the patient risk of recurrence with and without radiation?
Risk of recurrence with radiation is less as compared to risk without radiation.
No, that is very obvious. So that's why I give radiation. What number would you quote? What would you say if she doesn't go for? She said, I don't want radiation therapy. What is my risk of recurrence if I don't do radiation therapy? And what is my risk of recurrence if I do radiation therapy?
So if we do the radiation therapy, the risk of recurrence is 2 to 5%. And if we don't do radiation, the risk of recurrence is 20 to 25%.
So that's a good start. I mean, the number you are quoting is for all comers, but for somebody with favorable type, postmenopausal, ER positive, oncotype DX low, getting anti-estrogen therapy, then the risk of recurrence without radiation therapy is also on the lower end of the spectrum now. And this is the subset where people are trying to see whether we can skip radiation. We are not there yet, but people are exploring. Like look, so the risk of recurrence without radiation therapy is more in the range of 10 to 15%. And with radiation therapy for these cases in the modern era is more close to a couple of percent, but good start. Now say patient believes you and opts for radiation therapy. So let's go to the mic to the second student. So what radiation therapy would you prescribe her? Would you do radiation or not, first of all? Or you don't believe your colleague and say, I would not do radiation?
Yes, sir.
So you will do radiation therapy.
Yes, sir.
So what dose? So let us make it easy. What dose would you prescribe?
45.
I mean, there's no right or wrong answer. There are many options. Just put me one option. Let's pass on to the next one. Yes. What dose would you prescribe? Any one of you, any volunteer, like what dose would one prescribe? Or have you not seen a patient after lumpectomy at all? Anyone of you, what dose would you prescribe?
Sir, I would like to go for a low dose radiotherapy of weekly protocol. Maybe, and there is a chance I can send the patient for mutational analysis. As I read recently in a paper, it was we can go for pole mutation or MMR to check for.
No. This is pole is for endometrial cancer, not for breast cancer. This is breast cancer. So for breast cancer, routine patient walks into your office, has lumpectomy done. And we had one participant who said she will prescribe radiation therapy. I'm making it easier. What dose would you prescribe for radiation?
Low dose with 15 grays for 1 week.
15 gray for 1 week. Where is that regimen coming from? Anybody else? Anybody else?
Grain 15 fractions hypofractionated regime we can go for.
What
And followed by boost to the post.
Okay, so we have
Followed by the
one
boost.
good starts. You are saying 40 grain 15 fraction. Is that correct?
42 grain 15 fractions or
So
42.5 in 16 fractions.
There is no regimen of 42 grain 15.
Start trials.
It says, yeah, start trial is 40 grain.
Start trials.
No, start trial is 40 grain 15.
And
The Whelan trial is 42.5 and 16. So if you are saying start, then 14, 15 whole breast.
42.
That's one option. Any other option other than 14, 15? And you said boost, but we'll talk about the boost part a bit later.
Sir, can you read in the chat box? Some people have answered in the chat box. So somebody said APBA. 40 grade,
yes.
42.5 in 15 fractions.
So Dr. Churita, some person said APBI, accelerated partial breast radiation therapy. If anybody has heard of the term of APBI in the audience? Anybody has heard of the term APBI in the audience? Any one of the residents know about APBI? Yes or no? Those who have not heard, raise your hand. It looks like everybody has heard. Then tell me what like somebody in the chat box said he or she will do APBI. So what dose of APBI and what does APBI stands for? Speak up. There is no fear at all. No fear at all. Just speak up. The more you speak, the more your concept becomes clear. Otherwise, what happens? It becomes like a didactic session where Dr. Surita will speak and I will speak, and then nothing will come out of it. I want all of you to come out with some kind of concept after this. So accelerated partial breast radiation therapy. Good.
Radiation. Yes.
Good. And so can you tell me Since somebody in the chat box said they will do partial breast, what dose would you prescribe for partial breast?
So 42 gray for 15 fraction for partial breast.
First of all, there is nothing called 42 and 15. There is either 14, 15 or 42.5 and 16.
So-
But if you do 15 fraction, then it is not acceleration, no? The term is accelerated partial breast radiation therapy. So where is the acceleration? It is same as it's the same treatment which you would offer the patient if patient didn't have partial breast, no? Where is the term acceleration? Acceleration means it has to be accelerated. So any accelerated regimen, any one of you are aware of? Dr. Sunita, you can monitor the chat. If anybody says in the chat, let me know. So this brings up the important thing. Like I want, like we can talk all day long and create a didactic, but I want an interactive participation. I don't want to give a didactic.
Sir, I have some answers. There is
Yes.
Dr. Pramila who says accelerated partial breast irradiation 38.5 gray in 10 fractions. Other one, Naveen said 34 gray in 10 fractions. Then 34 gray in 10 fractions, 34 gray in 10 fractions. Majority of the people are saying. Aarti
Yeah,
also
so
said, yeah.
I think what people are confusing is 34 in 10 is with brachytherapy. It is
Yeah.
not with external beam. And 38.5 in 10 is a BID. Both 34 in 10 and 38.5 in 10 are BID fractionation schedule. So 34 in 10 is brachy, 38.5 is external beam. 38 in 5 has fallen out of favor because of higher complication seen in the Canadian study. So one of the commonest accelerated partial breast radiation therapy used is 30 in 5. Can anybody repeat what I said? 30 in 5. So the partial breast regimen which we commonly use here is 30 in 5. So this patient would be suitable for whole breast, 14, 15, partial breast, accelerated partial breast 13 in 5. Then there is another regimen of partial breast radiation therapy without acceleration. Can anybody say what dose would they prescribe in that setting?
1 second.
Partial breast
So-
radiation without acceleration?
So just to make it more interactive, we have enabled microphone for everyone. So whoever wants to answer, please unmute yourself and answer, and then please mute yourself back.
Yeah, that will make it more interactive. So those who said 34 in 10 in the audience, that's a brachytherapy regimen. That's an option for sure. 3.4 times 10 BID. 38.5 in 10 BID was an RTOG regimen, but because the Canadian study showed higher 2 to 2.5 times more fibrosis, it has fallen out of favor. Most of us don't use it. 13.5 is the Italian regimen. I'll show some example of that. And 14-15 whole breast is the start A regimen. Any other regimen other than whole breast 14-15, partial breast 13.5. Any other regimen people can talk about? Any other regimen for whole breast? Anybody in the audience? Anybody, and any other regimen for the whole breast? Anybody has heard of the term fast forward? So one other, yes, I think Dr.
You can
Swaran.
unmute yourself and speak up. Somebody wrote 25 gray in 5 fractions. 25 in
Yeah,
5.
not 25 in 5, 26 in 5 every day, Monday to Friday, is the fast forward regimen. So for her, 26 in 5 is also an option. And sometimes you can do partial breast, non-accelerated 14, 15 or 26 in 5. So there are various options available. And you choose an option which are equally efficacious but least toxic. So if you tell a patient that I can do 1 week treatment partial breast with similar efficacy than 3 weeks treatment, most women would not opt for 3 weeks. They will opt for 1 week. So this patient is suitable for any one of the regimen, 14-15 whole breast, 14-15 partial breast like import low, 13-5 accelerated partial breast, or 26 in 5 whole breast. As far as boost is concerned, boost tends to benefit younger patient, high-grade disease, triple negative disease, or with adverse factor. The routine boost for low-risk breast cancer has fallen out of favor. So this patient has ER positive, low oncotype DX breast cancer. the value of boost is very limited. But that being said, some
Sir,
people
it's a
do it.
grade 3 disease. Should we not
Yeah,
think
but
of boosting? Yeah.
Yeah, so grade 3 is a concept, but oncotype and MammaPrint trump over that.
Yeah.
So if it was you offer for high grade, you offer for you
It
can
was
offer
high
for
risk, but because of oncotype and
yeah, oncotype and MammaPrint are trump over traditional pathological factor in terms of outcome. So yes, but otherwise you can boost for grade 3. You can boost for patients younger than 50. You can boost for aggressive phenotype like triple negative breast cancer, and you can boost for people with partial risk. What is it? I can't hear it.
So they are talking among themselves. Can you please
Okay.
mute yourself, please?
Okay. Now, so this is what I was talking about. This patient had lumpectomy done, can get whole breast RT or partial breast. If this patient had mastectomy done, then no radiation therapy. For T1, T2, N0, no radiation therapy. Now, when you do whole breast radiation therapy for micrometastasis, say this patient had micrometastasis, then what is the option? Let me. If the patient has micrometastasis after lumpectomy, then what is the option? Then the options are you can do no lymph node dissection for sure. You do whole breast radiation therapy with high tangent, or you can do whole breast alone, or partial breast is also a reasonable alternative. If T1, T2 with micromets has mastectomy done, no radiation therapy unless it's triple negative or adverse factor. If it is macromets, then you also treat axilla and consider supraclav treatment, especially if they have younger age, extracapsular extension, aggressive phenotype, and other adverse factor. So in patients, have any one of you in the audience, those who are online or those who are face to face, have seen sentinel lymph node biopsy in their practice? You can type in the chat or you can speak up.
Yes, in our center, we do have sentinel lymph node biopsy.
Okay. So if somebody has a
sir.
sentinel for biopsy done and sentinel for is negative, do you do anything to the axilla?
Sir.
Okay.
If sentinel lymph node is negative, we won't go for axillary lymph node dissection.
Okay, so let's go one by one. What is a negative predictive value of sentinel lymph node then? What would you code as a negative predictive value?
No node is negative. No node is if node is not there, so sentinel lymph node is not it is called negative.
Yeah,
Dye
no,
is not uptake by that.
I understand. So if the node
Put
is
the number.
negative, what is a negative predictive value? What's the likelihood that patient has node negative disease? What's a negative predictive value?
More than 90%.
So yeah, so 95 and above. Now patient has sentinel for biopsy done, has and micromets. What would you do?
For micrometastasis,
What would you do if the patient has micrometastasis?
Radiating axilla if micrometastasis is there and sentinel is negative.
No, first of all, would you do dissection or no dissection?
If micrometastasis is there, we will go for axillary lymph node dissection.
Anybody has a different answer?
micrometastasis, we can just ignore.
Anybody has a different answer in the audience for micrometastasis or macrometastasis, what they would do? Please
Said
speak up.
axillary clearance in Khushbu.
No,
Khushbu
so I
says,
think the whole field has changed.
Yeah.
If somebody has lumpectomy done, then for centrifugal negative, that's the end of this axilla. For micromets, 1 or 2. For macromets, 1 or 2 node. You don't do dissection anymore for lumpectomy. You don't need to do dissection at all. For somebody with 1 or 2 positive node in centrifugal biopsy, whether it's micromets or macromets, you don't do dissection at all. You do, when you do whole breast radiation therapy, you include part of the axilla, and you may add regional load, like as I'm trying to show here. So these patients with macromets for 1 or 2 positive node, they're not undergoing dissection. They are undergoing radiation to whole breast with axilla also treated part of it. And when Dr. Sunita does the contouring guide, and she'll show what 1, 2, 3 and supraclav means. So your concept needs to evolve. We do not do dissection for micromets and macromets unless they have micromets and macromets after chemotherapy. So somebody gets neoadjuvant chemotherapy if they're micro and macromets, then yes, but not for upfront. Is that concept clear? Upfront surgery without neoadjuvant chemotherapy, somebody who undergoes lumpectomy, they do not undergo dissection. They get radiation and you modify the radiation volume accordingly. So I think this is now simulation. She will talk about it when you boost the volume. So this is the seroma of the surgical bed. Has anybody heard of the SIB boost for the breast cancer? Like instead of doing a sequential boost, do SIB boost? Anybody in the audience? Okay, they can put in the chat. So we talked about whole breast followed by sequential boost for high grade, younger patient, LBSI or other adverse factor. What about doing simultaneous integrated boost for breast cancer? Looks like nobody has heard. For those who have not heard, raise your hand then. I just want to make sure they've never heard about it. So there are published data on using SIB boost also, like the import high and the RTOG, where you can do 40 in 15 to the whole breast and 48 in 15 boost. So when you do the boost, you define the boost volume by either clip, seroma, or post-op changes. You can modify it, expand it 1 to 1.5 cm, and then few millimeter for the PTV, and then boost. If you do the boost sequential, what technique do you prefer? Let's bring back to the audience in the one of the student what technique of boost would you do? And what dose of boost would you do? Let's give the mic to one of the person in the audience.
Mike.
What dose and what technique of boost would you use?
Start from the first. They do.
You know, breast cancer is bread and butter of what we do. We need that what dose of boost would you use after 14, 15?
It's a boost of 48 gray boost will do, and by
No,
IG
48 grade is SIB, but you're doing sequential boost. So you gave 14, 15. What dose of boost?
6.
How many
6
fractions of boost? Is it 5 fractions?
6 to 7 fraction, ma'am.
What dose per
dose of
fraction? What dose per fraction? Anybody else? Anybody else?
So the most commonly followed one is the URTC boost trial, that is 16 gray in 8 fractions. Or since we are doing hypofractionation after 40 gray, we can do even 12.5 gray in 5 fractions.
Yeah, so you're like this.
Yeah.
Since we are doing hypofractionation, the boost is 10 to 12.5 in 4 or 5 fractions. That's a commonest boost schedule followed worldwide. So
most commonly, people have written in the chat box, sir, and they are giving 16 gray in 8 fractions or 10 gray in 5 fractions. Majority of them say 10 in 5.
So it is counterintuitive that you are giving hypofractionation to the whole breast and you're doing conventional fractionation boost for 16 fraction. I know that was what was done in START B, but there is a different reason for that. That was also done in FAST4. There is a different reason for that. But in practice, it's counterintuitive. On one side, you're doing shorter course for a whole breast and the longer course for boost. So if you go out and practice for the boost, 4 or 5 fraction regimen is fine. 10 in 5, 10 in 4, or 12.5 in 5. These are accepted regimen. So 10 to 12.5 gray in 4 to 5 fraction is what people would do for the boost. Now, what about technique, and what technique of boost would you use?
What technique, what photons, electrons, what do you want to use?
Treat by IMRT. Boost by IMRT.
And what about whole breast? How would you use the whole breast? What technique of whole breast?
For whole breast, for we do by IGRT technique.
No, but IGRT is the imaging. Is it IMRT, 3D? What are you using?
IMRT techniques.
Is it tangential beam or multi-beam?
He said
You're
multiple.
muted. Yeah,
No,
like
she's
I
multi.
wouldn't, like there is absolutely no reason to do whole breast multi-beam IMRT. There's absolutely no reason to do. The partial breast will talk about it. The whole breast, commonly used technique worldwide for whole breast is tangential beam. You can use sliding window, field within the field, or inverse optimization for dose homogeneity, but you don't need
Rahul
to
answered.
do. Yes,
Rahul answered in the chat box. It is field in field.
yeah, so field in field is a 3D technique. You can do inverse optimization, but don't use IMRT for whole breast routinely. There are very uncommon scenario you can do it, but not for routine whole breast. That's one thing. Secondly, you prefer, if you do sequential boost, you prefer electron beam if the depth is suitable up to 4 cm, because your integral dose is low. You can focus on the surgical bed, your dose to the other part of the breast tissue is low. When you do multi-beam or photon, you treat more breast tissue. So whole breast tangential beam with field within the field, as Rahul put in the chat. You can use inverse optimization for dose homogeneity. And then the boost part of is electron. But if you do SIB, then yes, you can use a different technique, either 3D or IMRT. So let's go to the thing. What now, if you do whole breast radiation therapy, what dose would you limit to the heart? Anybody, you can put in the chat and people can put, say online, but what dose would you give? What would be a heart structure limited to? What dose? So you're treating left-sided breast. You're treating left-sided breast cancer.
Less than 2
and
gray.
you have, what is it?
Rahul answered less than 2 gray.
Like Rahul said less than 2 gray. Like anybody in the audience has had a different answer. And what is that 2? Anybody in the audience has a different answer?
Mean dose, he said. Rajesh says mean dose less than 3 gray. Monica says less than 4 gray.
4 gray. Okay. Anybody else? We have so many people in the audience.
Yeah.
What about people here at Jammu who are online? I want one answer from one of you.
For the heart.
What? Just say a number.
So you can specify whether it is only BCS or
No, this patient. No, this patient. I'm talking about this patient.
Yeah.
Less than 2 gray.
Okay, good. So, first of all, we don't need gating for breast cancer. Somebody put in the chat. I'll talk about the technique. But in the modern era, if you're treating somebody for early stage breast cancer, post lumpectomy, your dose to the heart is closer to 1 gray or below. Even 2 gray, less than 2 gray is probably the most practical way I would look at it. Less than 3 or less than 4 may be acceptable if you're doing regional load. Each gray to the heart matters. You are impacting local control, but you may cause long-term cardiac morbidity by increasing the heart dose. So in the modern era, you have to limit the heart dose to less than 2 gray. In our own practice, it's usually 1 gray or below. But that being said, and you don't do gating. I mean, I'll show the technique. So for early stage breast cancer, the mean heart dose is 1 or 2 gray. And how do you do it? You put no beam through the heart. So absolutely no beam can go through the heart. You can use deep inspiration breath hold technique. You can use conformal heart block or prone positioning or partial breast. No matter what any one of the technique you use, if you do whole breast, deep inspiration breath hold, conformal heart block or prone positioning, or partial breast. But if I can send one messaging out to you people who are in the audience and listening face to face, mean heart dose in the modern era for breast cancer is low. It is closer to 1 gray. The only reason heart gets a dose is through scatter and transmission. No beam can go through it. You contour the heart, contour the LED, make sure that the beam doesn't go through it. and use any one of the technique. If you don't have deep inspiration breath hold, put conformal heart block. If you don't have conformal heart block, prone, do partial breast. And when you contour the heart, Dr. Sunita will talk about it. Start from the bifurcation of the pulmonary trunk, just to make your denominator is okay. So this is what we are talking about, deep inspiration breath hold, where you hold the breath and separate the between heart and the breast. Let me just see. And this is the example of the prone. You can see it decreases separation, so makes the homogeneity better. It decreases skin fold. Heart and lung dose for most situations tend to be lower in prone, although once in a while it can be higher if the heart falls forward. But a lot of time you need to have a setup, large bore CT, prone board, and patient need to be comfortable. I've seen some patients are not comfortable. We used to do it, but sometimes patients are not comfortable. You need to have large bore CT, prone board, but you can see the beam is like compared to this. You can see the beam is so far away from the heart. Now, this is the example of conformal heart block. You put a heart block 5 millimeter outside the heart and treat it, because if your surgical bed is above, you can do it. So any one of the three technique would do. Now, this is what I was talking about. 14-15 is standard of care because they have similar local control, possibly less acute and chronic effect. You can do partial breast with 14-15, like you can, it's called mini tangent. You just decrease the upper and the lower border from the surgical bed, from around the surgical bed. And this helps out in large breasted women where you can decrease the toxicity. So 14-15 whole breast, 14-15 partial breast with mini tangent. The boost could be 4 and 5 fraction sequential with electron or photon, depending on the depth. You can do SIB 48-15, like import high in RTOG. And the shortened courses are 26 in 5 whole breast, which is we do it routinely for postmenopausal early stage breast cancer, or partial breast 26 in 13-5. Any question on this slide? Because this is what we discussed for the last 20 minutes. This basically summarizes the fractionation schedule for early stage breast cancer.
So I would like to ask in obese patient, like what would be the technique and
So
what
for
we could
example,
use?
if somebody is obese and has early stage breast cancer, there are two things you can do. Sometimes you're not sure about the setup, then you can do import low. Like for example, you do mini tangent 14-15. The import low show less toxicity compared to whole breast. Patients who have larger BMI and larger breast have higher complication, no matter what fractionation you use. So by decreasing the volume, either import low, or if I have a necessary resources, I would do partial breast 26 or 13-5. I usually do 13-5 partial breast because I can minimize the dose to the other part of the breast tissue, which will decrease the toxicity. So in obese early stage breast cancer, I'd either use 14-15 partial breast or accelerated partial breast 13-5. Now one other question comes up, and I will ask the people in the audience first. And for those who work for AOI, they can hold up their answer because we have discussed this many times. How do you assess dose homogeneity? So for people in the audience, both live and online, how do you assess dose homogeneity of your plan? What parameters do you use? Say if you use 14-15 or 26-5 to make sure the dose distribution is good. Anybody here first?
How do you assess the dose homogeneity is the question.
For those who are surprised, it's early morning here. That's why I'm the tea. Okay. How do you assess dose homogeneity? Anybody?
Somebody in the chat answered CI and HI.
We can also
Conformity
check
index and homogeneity.
for the hotspots and all. If hotspot.
Yeah. So I mean, it's not truly in a hotspot, but we use the term hotspot. Hotspot is usually outside the target, but the target is breast tissue here. So what would you limit your hotspot in the breast tissue to? So conformity index and homogeneity is more for when you are trying to do a large volume IMRT or a brachytherapy. For breast cancer, we don't use conformity index and homogeneity index. We can simply use, say, the volume of breast tissue getting 105. What number would you limit to? People can put in the chat, or people in the audience can also answer. When you're looking at V105, what number would you aim for? I mean, these are important concepts, and you're like, when you go back after today's session, I want you to write these things down in your practice, like in terms
Rajesh.
of.
Rajesh
Go ahead.
says V105 less than 10%.
Yeah, so V105 less than 10% is a good idea, but when you do
Tmax
fast
110%.
when you do fast forward, then the V105 has to be less than 5%. So this is how you assess dose homogeneity, and this is what field within the field when Rahul said that. You try to make sure you don't have hotspot in the inframemory port, this 105. You use multiple subfield, usually 3 or 4 subfield to decrease it. And your absolute V105 is less than 10%, but if you're doing fast forward, it has to be less than 5%. So V105 less than 5% for fast forward, less than 10% for other fractionation. No V105 in the fold or areolar region. So you avoid V105 in the fold and areolar region. You look at the DVH and you try to make sure your V105 is less than 10% or less than 5% with nothing in the fold. So visually, even though V105 may be less than 5%, if it is in the fold, I would not accept it. And you can see you put field within the field. So you block it to reduce it. You see, you put field within the field to block it. So this is how you are trying to achieve it. And this is our published data, where we saw that if we keep V105 less than for hypofraction less than 10%, the risk of grade 3 dermatitis is less than 2%. This is published in Red Journal. This is one of the largest series in the literature talking about dose homogeneity in breast corresponding to skin toxicity. And you can see that if we kept V105 less than 10%, the grade 3 dermatitis was less than 2%. For fast forward, it is less than 5%. Is this concept clear? If it's not clear, please do ask. I want to make it clear that you go back, and I would like all of you to go back and look at your last 5 breast patients you treated, whether you achieve these constraints or not.
Rahul answers, we used absolute volume most of the times as compared to the percentages, with a target of V105 being 150 to 200 cc. That's a huge number.
No, that number was done in the Astro guideline. I would say that's very big number. We looked into it. And if you read this paper, in this paper, we talked about absolute volume also. That doesn't correspond. And that 200 cc number, which our Astro guideline has, is a big number. I would not go for that by number. And pull this paper, it's in 2019 Red Journal. This is the largest series in the literature, which talks about it. And in fast forward, they kept it to less than 5%. If you have 200 cc, somebody has a 1000 cc breast, which is a average above average breast size, 200 cc will be 20%. That's a very high number. Is this concept clear for people in the audience and the chat? Because this is very important concept. I do see people not understanding this concept and not implementing it. In our series, you can see 68% were field within the field and 32 were tangential beam IMRT, not multi-beam IMRT. Just IMRT, a sliding window for dose homogeneity. So either tangential beam or 3D field within the field. You can see electrons were used majority of the time. The concept which I'm discussing, you can see in the practice, this is what we are doing. Just for you to show the example. Is the concept clear? Looks like nobody's listening. Maybe Dr. Abrol has organized nice food and drink there. People are enjoying it.
No, he didn't feed us lunch also today.
Or maybe they're starving, they're hypoglycemic. Now, this is an example of partial breast. So where you basically treat part of the breast tissue. 1 second, let me see. So I got a wrong picture. Partial breasts. We define the surgical bed, expand by 1.5 centimeter for CTV, edit out the muscle and the skin, then add 3 to 5 millimeter for PTV, and then we treat that volume for partial breast multi-beam or BMAT, 13.5. And when we do that, we follow this constraint. And one of the most important constraint for this patient is this one. The remaining part of the breast tissue. So if you give 13.5, 50% of the dose, which is 15 gray, should be limited to less than 50% of the uninvolved breast tissue. So if you draw the breast tissue, you subtract the PTV, and you look at the number, and you make sure that 15 gray is less than 50%. Other important thing here is dose homogeneity. You can see this one also, the dose homogeneity is very, very significant. Like V105 used in the original trial was like 0, although now they accept up to 5%. In the original trial, the V105 was 0. Like you can see this, the maximum dose was like 3150. Now they have relaxed a bit, and this is the coverage. So what you're looking at is basically 13.5 partial breast cavity plus 1.5 cm margin for CT, 3 to 5 mm PTV, multi-beam or BMAT. You give good coverage, like the 95% of the dose is delivered to 100% of the volume. Hotspot limit to 105, although in the new one they've relaxed a bit, and also uninvolved breast tissue. Any question on this? Looks like the audience is very clear. And then Dr. Sunita will talk about indication for regional load. So when we talk about regional load, we mean axilla and supraclav. And one thing I just want to emphasize, when you use the word supraclav in literature, it usually means undissected axilla and supraclav. So from people in the audience, when we what level neck node is this? The one I'm pointing out, what level neck node is this? People can put in the chat. If I have to quantify what level neck node is this?
Can everyone mute him? Can everyone mute themselves? Yeah, we have disabled the mics.
Yes. Can anybody put in, like, for people, like, give the mic to the people in the audience? What level neck node is this?
Most of them answered as supraclavicular.
Yeah, but supraclav is a very colloquial term. I want to explain that. When we use the
Two
word
answers
supraclav,
said as level 4. Somebody said
4A,
level 3
lower jugular.
and level 3 again.
okay.
So
good.
there are
So
variable answers. Level 3, level 4.
So level 4A, lower jugular.
Good. So first of all, level 3 is not part of supraclav. As we heard from the audience, level 4A, which is the medial supraclav, is what we treat. So supraclav has medial and lateral. In breast cancer, we treat medial, which is level 4 neck node. We don't treat lateral. That means we don't treat node behind sternocleidomastoid unless medial is involved or there is significant nodal burden. So as rightly pointed out for somebody in the audience, level 4 is the supraclav. But when we use the word supraclav, normally what we mean is that undissected axilla, which is level 3, and supraclav. So if somebody has level 1 and 2 dissected, when we use the word supraclav, we always include undissected axilla and neck node. So supraclav doesn't necessarily mean in the literature, when you talk about it, the word means undissected axilla and neck node. And as rightly said, medial supraclav. The lateral supraclav we don't treat unless medial is involved. We don't treat level 3 node unless level 4 is involved. So level 3 is not included. We don't go above the cricoid. So level 3 is not included. Level 4 is included. Medial supraclav is included. And undissected axilla, which is level 3, is also included. These two are only included if there is incomplete dissection or only central for biopsy done and you're treating the supraclav. So level 1 and 2 are included in case of inadequate dissection, but level 3 and supraclav are routinely included. So when you say the word supraclavicular field, it includes neck node, and this is the IM node, and Dr. Sunita will talk about. The reason why she is talking about these aspects is the quality of nodal radiation therapy is important. If you do not contour the right target and you treat the patient with nodal radiation therapy, the value of nodal radiation therapy is only 3 to 5% improvement in disease-free survival. If you look at the two large trials, the MA20 and the EORTC, 2% improvement in disease-free survival. But if you're not contouring correctly, you'll not see that advantage. So it's important that you contour appropriately, cover appropriately, and have the dosimetric constraint met. If I cover regional load and give hard 5 gray or 6 gray, 7 gray, I mean, the small benefit of disease-free I may negate by cardiovascular morbidity. So it's important dosimetry constraints are met and the quality of the nodal contouring is good. In our paper, when we looked at audited it, we found about 15% of the time either the quality of nodal contouring or the coverage or the definitions were not correct, which will negate the advantage. Like now when I show this, so for people in the audience, the figure B, what's wrong with figure B? Anybody? Give the mic to the people in the audience. And for people in the chat can also type in. What is wrong with figure B? And what is wrong with figure A also, if you're trying to treat medial supraclav? What's wrong with figure A and what's wrong with figure B?
Identify the problems in these figures. First one, second one.
Please speak up. This is your forum. I can keep doing the didactic. That's the reason I don't. That's the reason I don't commit to too many didactics, because I want like the effort of what we put in translate into. Yes, go ahead.
In image B, level 2 and level 3 lymph nodes are taken. Level 3 lymph nodes are taken.
Taken or not taken?
They are taken.
So then that's not a problem.
Level 3 is not taken.
No, level 3 is part of the volume there. So say this is level 3, it's included. Would you include the ribs in the volume for the CTV?
No.
So that's rib, and would you include this muscle in the volume?
No.
Yeah, so this is level 1. So level 1 is not included if they wanted to include it, which may not be the case.
From the chat, picture 1 has a lot of muscle included.
Good. So people are getting it. So let's go on. So this is level 1. This is pec major, latissimus dorsi, and subscapularis. Level 1 is not included, which may be the case. Level 2 is interpectoral node, or rotatus node, and around it, they have gone too far deep, which is okay, but you are including the muscle, which you don't need to include. You have included the ribs, which you don't need to include. You have included the intercostal muscle, which you don't need to include. You have included the pec major, we don't need to include. Pec minor you can include because they're rotatus node, but you don't need. This is level 3. So this is the subclavian vein. You can see level 3, level 2, and level 1. Lateral level 1, in between level 2. So level 1 is not included. Ribs and intercostal muscle are included. Muscle, pec major is included, and a clavicle is included. You don't need to. In this picture, we talked about that. One is you're including a lot of muscle. That's one. Second thing we talked about, you only include medial supraclav. The medial supraclav, the border is sternocleidomastoid, which is this. But they have included the lateral supraclav also. We don't need to include lateral supraclav, which increases the volume. So it's good lateral supraclav, lots of muscle. So these are important. If you do 3D, it may not matter as much, but what happens, your dosimetrist or physicist will increase the depth of tissue which you treat. If you increase more depth, more lung dose. If you do IMRT, you are treating unnecessary a lot of tissue. So in both ways, it is not correct. So it is important that the treated nodes are contoured appropriately, the dosimetry is done appropriately, so that you have. Now, what I would these are the contouring atlas. Dr. Sunita will do it. So I'm going to skip it. I'm going to skip this also. Now, this chest wall contouring. Anybody has any issue or question with that chest wall contouring? People in the chat can chime in, and people in the audience, we can give the mic to them. This patient has, say, T2N1M0 breast cancer, and this is how the chest wall is contoured. Please chime in. I mean, yeah, because like I always emphasize when I give this kind of talk, your young mind. Tomorrow, if I develop cancer, you will treat me. And you are the future generation, and I want to make sure that whatever little information, knowledge I have impart on you, because you are the one who are going to treat the family member, the friends, including myself. None of us are immortal. We'll all are prone to developing these things. So
Sir,
go ahead.
so in picture 1, muscle and it is also irradiating the skin is also covered in that picture number 1 with the chest wall.
So skin could be the target, no? Skin is one of the site of the recurrence, but so skin could be the target.
It should be below skin. It should.
No, the CTV goes to the skin. I mean, you can, for PTV, you can decrease it, but CTV does go to the skin. So what is more important than that?
Bolus should be used.
Yeah, but that's the planning part of it. This is the contouring part of it. And bolus is questionable. Like routine bolus has fallen out of favor unless skin is involved or inflammatory breast cancer. The important thing is, yeah, so important thing is rib and intercostal muscles are included. Yeah, and that is not the target. And this is the RTOG atlas. So another important thing, just because an organization has come out with the atlas, don't follow blindly. So I wrote a letter to the Red Journal regarding this atlas, and I'll show you what we wrote. So in the RTOG atlas, they include ribs and the muscle, which most of us don't. In the EORTC atlas,
Naveen and Tabitha got it right. Ribs.
Good. And so in the EORTC atlas, they don't include the muscle, which I feel is too skimpy. So if you look at the other thing I noticed, and Dr. Sunita will talk about chest wall contouring, people put a mark in that those, and they go that far to the mark. If I would not go beyond this serratus muscle. So this going beyond this serratus muscle increase the volume significantly. Use this as a rough landmark of how far you need to go posteriorly, and Dr. Sunita will cover it. But ESTRO guideline says anterior to the pec muscle, unless patient has T4 disease, and the RTOD says include the muscle and the ribs. But we looked at the recurrence pattern. This is our editorial in the journal, or a letter to the editor. We showed that the recurrences are either anterior to this pec muscle, most of it. About 1/4 the recurrence is in the pec muscle. The recurrence behind pec muscle is very rare. So we said include skin, pec major and pec minor. Don't include rib and intercostal space. And only treating skin is also probably too skimpy. Because if you look at it, yes, that's a commonest site of relapse. But if you look at the studies like MD Anderson, Bryn Mawr study, you can see some of them do have recurrence reported in the pec muscle. So I include skin, subcutaneous tissue, pec muscle, and pec minor. At least pec muscle for sure, but I don't go behind pec muscle at all. I don't include rib and intercostal space. And that way you can decrease heart and lung dose. So I don't follow this one. This is too far extensive. And let me just go through the thing. And technique is the commonest is partially wide tangent or matching photo. I don't think we have time for that. And then sometimes you do IMRT. It's better coverage, more conformity, but more low dose spread out. So you do it if needed, but not necessarily. And for the patients, like for example, for these patients also, I use hypofractionated course 14-15, except if they have inflammatory breast cancer or poor response to chemo, or gross node is not taken out, then I may do different. So right now I'm not doing 5 fraction for these. We need more data. So I do 14-15 for whenever I add regional load. But if it is inflammatory breast cancer or poor response to chemo, to give, if I ask you 14-15 is equivalent to what dose 2 gram per fraction, what answer would people give? Let's give the mic to the people in the audience.
Sorry.
What dose? What is it? The equivalent dose? Any one of you? Anybody in the chat? As people are typing in, I'll just go. And this is we recently published for hyperfractionation lung dose. We showed that V20 is less than 26%. None of them had symptomatic pneumonitis. That's not the upper limit. I mean, upper limit would be more than that. But if you keep it below that, the risk of pneumonitis is low. And these are the dosimetry constraints, and you can see the mean heart dose has gone up because of the regional node. And these are some of the coverage things. Anybody could come out with the answer? What's the equivalent dose? So with this, I will conclude, but I would strongly encourage young minds to be open about it, to be ready to speak. There is no wrong or right answer. I mean, and if you say wrong things, you retain the right answer much more better than those who don't say anything, because your mind clears up. Each time I give this talk, I learn a lot from my own interaction. So there is no end to learning, but please keep an open mind and learn how to interact and speak. Question your faculty, question your bosses, question your attendings, question the people you work with, because none of us are absolute. None of us know everything. We all are human beings. We make mistakes.
50 to 15 fractions.
What is it?
50 to 15 fractions.
I didn't understand. 50 Gray, you said? Can you speak again? Yeah, go ahead.
50 to 15 fractions. 15 fractions.
No. What I asked was 40 Gray and 15 fraction is
50.
equivalent to what? 50 Gray, you said?
50.4.
Yeah, so that's not the case. And that's so if you look at the whole START B and hypofractionation study have given a different perspective. So 40 Gray and 15 fraction, depending on what alpha beta value you use. And now for breast cancer, people use closer to 3. It is equal to more closer to 45 Gray. And that's one of the reasons why side effects are low, because we were given 50 Gray. And now we are giving equivalent to 45 Gray. And that's why the acute side effect and chronic side effect are low, not because of hypofractionation. It's not the hypofractionation which is causing the less side effect. It is the total dose which we are delivering is less than what we were doing before. But the studies have shown we don't need 50 Gray equivalent. We can do 45 Gray. So better dose delivery and better dose homogeneity helps out. But the less total dose is one of the factors. And that's why in patients with inflammatory breast cancer, I want to give higher dose. That's why I tend to give 15, 25 with boost. People with poor response to chemo, I want to give higher dose. Maybe I'm not right, but I do tend to give. And if somebody has an IM node or an axillary node which has not been dissected, I want to give higher dose. So that's the reason. But otherwise, 14, 15 is equal to more close to 45 Gray. Any other questions? I mean, I'm going to conclude and give it to Dr. Sunita. Any questions from the audience or the chat before I conclude and give it to Dr. Sunita?
If posterior margin is involved after surgery and the depth of invasion is more, then should we include muscle or ribs in that case?
So muscle I always include. I did say I do include pec muscle but usually the posterior margin is pec muscle margin. It's not the intercostal or the rib margin. You include intercostal rib if the chest wall is involved, because that's what you can include intercostal rib if it's inflammatory breast cancer, because most of the studies recurrence patterns are not for non-inflammatory breast cancer. In inflammatory breast cancer, the dermal lymphatics involvement, the recurrence pattern tend to be different. But if the posterior margin involved, it's usually the anterior to the pec muscle. So you include the pec muscle and you boost that area. But you don't need to include intercostal in the ribs because of posterior margin. It's not a rib margin, it's a pec muscle margin. In literature, when you talk about deep recurrences, usually they are IM nodal recurrences, which Dr. Sunita will talk about contouring for them. So you don't need to include intercostal rib for posterior margin. For the bolus part of it, the practice of bolus have fallen out of favor unless skin is involved, anterior margin is involved, dermal lymphatics is involved. So more and more of us don't routinely use bolus in the practice.
There's a question
Any
in
other
the chat,
question?
sir. Anterior aspect of serratus muscle as a reference for CTV or for PTV?
I think I don't go beyond that, because like I don't even go beyond that for my PTV for the chest wall, because what happened is that I mean, if you give contrast, you can use the blood vessel as a landmark. But what I've seen commonly is like if I show you the thing, like what I've seen commonly, and I'll tell you what I've seen commonly. And then what happened? The volume becomes significant. Like if you look at this, people tend to, like you see this mark, people tend to contour the chest wall up to the mark. They will take the medial up to the midline and now give PT margin, it goes across. So unless patient has lower outer quadrant, closer posterior margin, you don't need to go beyond this, the scapular muscle. You don't need to go beyond the scapular muscle. I mean, you bring it here, now you are treating a big tangent going to the heart, and that's not what the recurrence pattern supports.
There was a lag in, sir, there was a lag in the signal. Can you please come again?
Can you see? Can you hear it now?
Yeah.
So what I commonly see is people contouring chest wall up to the midline, and they put a mark and they bring up to the mark, and this whole curvature becomes too long to treat, and now you're treating the lot of heart tissue. So if you use this muscle anterior landmark, I use this as a rough landmark. I sometimes go more anterior to it, but I never go posterior to it. Now, sometimes you have a scar which goes posterior. Then what happened in that scar area, you can go posterior, but not in the entire chest wall. The other thing I know, so not in the entire chest wall, you don't need to go that far posterior. You can go in only the scar area. That's one thing. Second thing I notice is people make chest wall contour rectangular. If it is rectangular, it's too large a volume. In the top and the bottom, it should become conical. So as you come lower down, this whole thing will become less and less, and it become conical. And that way you are decreasing the volume. If you make it rectangular, then again, you're treating much more. So chest wall contouring is an art and science in terms of where you find the disease, what is the location, and you modify and adjust accordingly. Good. Any other question? I hope you got some messaging out of it for fractionation, for technique, for volume, for homogeneity, for hard dose, and go back. I mean, you don't need to get everything out of it, but if you can get that out of it, go back and write it down, read the relevant literature to support it, and please speak up. Next time, this is not the end of it. Dr. Abrol will do it again for some other topic. Next time when we do it, I want to have an interactive audience. If I'm like, I just don't want people to do the didactics and when you are sleeping and I'm also half asleep and not getting anything out of it. Good.
Thank you, sir. Thank you for enlightening talk and guiding us how to do it properly. Thank you so much for sparing your valuable time, sir.
Thank you. Thank you.
Request Sunita ma'am to take over.
So I didn't want to make any slide presentations here because we have heard many presentations till now, and it's always better to see in a real life scenario. Can you see the slides now? The ARIA system now? You can see. Right. Okay. So we have right now, for the students who are here, we have selected 4 cases, 2 BCS and 2 post-mastectomy. And I have selected a right side post-mastectomy case. And this was a little bit complicated to see. That's the reason why I thought I will contour on this. The rest of the 3 cases, you can contour yourself. And I mean, as I finish off this, I can come down and help you out if you have any problems in any of the case.
Which case?
I mean, let them see the contouring first. Okay. Okay. So initially I said, I mean, for those who have joined late, let us just quickly revise these arteries. The left subclavian artery, the common carotid artery, and the right brachiocephalic trunk. So we are more interested in seeing this subclavian artery, I mean vein. This vein is passing over the apex of the lung and is entering into the axilla, and there it continues as an axillary artery. So first we'll begin off with the IMN nodal contouring, that is internal mammary nodal contouring. So as of now, the indications will be whenever the patient has an internal mammary node positive, or for elective nodal radiation, we need to have an N2 or N3 disease in the axilla, or a medial quadrant disease with a N1 disease in the axilla. All these situations, we do radiate the internal mammary nodes. So again, as I said, it is based on vascular marks. So first what we'll do is, we have to include the first 3 intercostal spaces for the internal mammary nodes. First, we will identify the lower border of the third rib. That is the cranial border of the fourth rib. So as we scroll from the, I'll show you how to see. The best thing is to see in the coronal section. As we scroll from posterior, yes, I know. We'll finish off. I'll just finish off in 10-15 minutes about this contouring, and then students can take it out. So I'm scrolling from posterior. You can see I'm scrolling from posterior to anterior. First, I want to see where is the sternoclavicular joint. So this is the sternoclavicular joint. Let me enlarge this for you. This is the sternoclavicular joint, and this is the first rib which is joining the sternum. First rib. Then let us trace the second rib. Okay, we have come to the second rib. Then again, let us trace the third rib. So this is at the junction of this third rib, and this is the fourth rib. So we want to go superiorly at the cranial border of the fourth rib. So this will mark our inferior border of the IMN node. So I have scrolled in the coronal sections from posterior to anterior direction. I've noticed where the sternoclavicular joint was there. From there, I have counted what are the number of the ribs, and here I landed in the fourth rib. Okay, so that will mark my internal mammary nodes. Where is IMN? Yeah, I'll switch on the IMN. I've done a little bit homework. I know Vibhor will push me forward. So this is the internal mammary node. So we have done the homework. We have come to the cranial border of the fourth rib, and this will mark our internal mammary nodes inferior border. So the other borders will be very simple. You just go 5 millimeters on, on either side of the vessels. You'll take a 5 millimeter brush. On the medial one will be the vein, and the lateral one will be the artery. So we will go 5 millimeters around the vessels. Posteriorly, we'll take care that it doesn't enter into the lung, and anteriorly, it has to be just 5 millimeters above the vessel. So we'll trace like this till the superior border. So what is a superior border? In RTOG, they said it is first rib. But now, since we are going with the ISRO guidelines, the inferior border of the level 4 node will be the superior border of the IMN node. So what is that? We'll see. First, we need to identify the subclavian vein. So this is the subclavian vein. And from the subclavian vein, let me show you on the coronal section also how it is arching over the subclavian vein, over the lung. Okay. So when you scroll from anterior to the posterior, this is the first vessel you see. So your inferior border will be 0.5 centimeters below the subclavian vein. So this is the inferior border, and from here you have to be 0.5 centimeters below that. That is your superior border. Okay, so that is your superior border. We stop the IMN nodal contouring above the, at the level of 0.5 centimeters below the subclavian vein. I've shown you how the subclavian vein looks on the coronal section. I've gone 0.5 centimeters below that, that has marked my superior border of the IMN node. And as I told you, this nodal margin, I mean, this margin will be the same margin as for the lower border for the supraclavicular node or the level 4 node. So for the level 4 node, so any questions for the IMN node? We have done with the IMN node. Let me do it again. So we start from the caudal border of the level 4 nodes and go up to the fourth rib superiorly, and then 5 millimeters margin around the vessels, taking care not to enter posteriorly into the lung. Okay, so that's it. And then this is one thing which has come up in the recent RADCOM atlas. Just for the sake of completion, I'm telling you, in the superior sections, what happens is the artery arises little bit higher compared to the vein. So in the superior sections, we'll see that the vein will not be visible. So don't chase for the vein in the superior sections if you want to follow the RADCOM atlas. And this is done only when we have a nodal positive disease. Otherwise, routinely, it's not required. If you just go at the caudal border of level 4, that should be more than enough. So in these superior sections, we see only the subclavian, internal mammary artery. There won't be any vein. And this is the mark where we see the vein which is draining into the brachiocephalic artery. So if we have to follow this RADCOM atlas, what happens is there will be lot of dose, which has to be thrown here. Maybe we might be radiating lot of lung. So let's keep it simple. Now we'll go ahead with the level 4 nodes. Level 4 nodes, we have already discussed. I've drawn this, kept it ready. So level 4 node is where the IMN node ends. Okay. From here, that is 0.5 centimeters below the subclavian vein. This is the lower border of the level 4 node, 0.5 centimeters below the subclavian vein. And then if you follow strictly the ISRO guidelines, it only says that you have to be not more than 0.5 centimeters above the subclavian vein. So it has to end here. But for our patients, this is my personal choice. I don't stop here because what happens is there are chances of recurrence. So as I told you initially, we have to individualize and customize to our own patients. This was initially kept for the early stage breast cancers, but now we do get lot of advanced breast cancers. For that reason, I went here up to the lower border of the cricoid cartilage. Let us trace the cricoid cartilage. This is the cricoid cartilage. We'll go below that. Yes. And that is where the cricoid cartilage ends. These are only the vessels. Let me switch off the vessels here so that there won't be any confusion. Drawn only the, kept only the level 4 now. So level 4 superiorly, as I said, I will go up to the lower border of the cricoid cartilage. Then I will include the internal jugular vein. And this is again a new thing which has come up in the ISRO guidelines, which says that you can avoid the internal carotid artery here. The common carotid artery or the internal carotid artery can be avoided here. It is not required because most of the times the nodes are situated in and around the vessels. And but if you see the RTOG guidelines, they include the common carotid also. It is your individual choice. What I have done, just to show you clearly, I have excluded this, but in clinical practice, I would prefer to include the carotid artery also. Right. So anteriorly, we need to go up to the sternocleidomastoid and then up to the rib, up to the clavicle. Then posteriorly, it should be going up to the ribs and the intercostal muscles. In the superior sections, the ribs will not be there. So we just go 5 millimeters below. You don't need to be so generous till here because these are all only the muscles. Then one new thing which has come up in ISTRO guidelines is that the scalene muscle will also be included as part of the supraclavicular node. The reason being that it, as I told you in the anatomy section, that this muscle insertion is in between the artery and the vein. For that reason, maybe we might be missing some infraclavicular nodes, which is a pattern of recurrence in breast cancers. For that reason, they recommend to include the scalene muscle posteriorly. So this is how it goes for the level 4 nodes. And level 3 now. So this will follow only the ISTRO guidelines. Again, let us see where is our subclavian vein. Always it is easy to start with the superior and the inferior borders. Once you identify the superior and inferior borders, it becomes easy for us to go forward. So this is the subclavian vein, and level 3 will be 0.5 centimeters above and below the subclavian vein. It's very simple. Identify the vein, go 5 millimeters above the vein and also 5 millimeters below the vein. That will mark the superior and inferior borders of the level 3 nodes. So we have to be careful to include all these vessels, that is the subclavian vein, when it is crossing between the ribs. So it has to be a continuous structure. So if you compare with the RTOG atlas, there used to be a gap between the level 4 and the level 3 nodes. So there is always a chance of missing nodes in the infraclavicular area. That's the reason ISTRO has come up with a continuous nodal delineation. So there won't be any gap between the level 4 and the level 3. So level 3, as I told you, it is 5 millimeters above and below the subclavian vein. And laterally, we will stop at the pectoralis minor muscle because this will go into the level 2. So laterally, it is pectoralis minor muscle, anteriorly the pec major muscle, and posteriorly up to the ribs. Do not include the ribs or the intercostal muscles. So this is about the level 3. So next we'll go ahead with the level 2 nodes. Although ISTRO separates the interpectoral nodes as a separate entity, in clinical practice for the routine work, it becomes a little bit cumbersome for us to draw this volume separately and level 2 separately. So what I commonly do is I do it as a level 2 only. So for the level 2 and level 3, level 1 nodes, again, we need to see what is the superior border. So in RTOG guidelines, it used to say it has to start from the pec minor insertion into the coracoid process. So this is the coracoid process, and here you see the pec minor muscle. So it used to be a very high volume, almost all radiating part of the humerus also, and leading to a lot of frozen shoulders. So now here in ISTRO guidelines, what we do is we identify the axillary vessels. Now let us see the axillary vein. So as I told you, once the subclavian vein crosses the rib, it is called as a axillary vein. So here it is the axillary vein. We go 0.5 centimeters above the axillary vein. It means you're not going that high. This volume is going to be very less. Remember, for level 3 and level 4, we said it is subclavian vein. And for level 1 and level 2, we say it is axillary vein. For level 1 and level 2, we identify the superior border as 0.5 centimeters above the axillary vein. So here we see this is the axillary vein, and I have gone only, let me enlarge this for you. This is the axillary vein, and we have gone only 0.5 centimeters above the axillary vein. So that is the level 1, level 2 node. And the other borders are just like an RTOG, we include up to the posterior border of the pectoralis major, and inferiorly, we try to go up to the ribs and intercostal muscles, but not include the ribs and intercostal muscles. And laterally, it should be up to the pec minor muscle. It should have been till here only. Right. So let us switch on the level 1 also. So as I said, previously I said it is 0.5 centimeters above the subclavian vein. So where should we end the level 2? Level 2 should be ending where the pec minor starts arising from the ribs. Initially, we said it is from 3rd, 4th, and 5th ribs. From here, we don't see pec minor muscle anymore, and that is where we need to stop the level 2. Then level 1. Just for the sake of completion, I'm completing this level 1 also here itself, because normally after a complete axillary dissection is done, we do not treat level 1 or level 2. But this is not a hard and fast rule, because you have to see the surgeon whether they have really done the level 2 dissection there or not, because majority of the times, majority of the times level 1 and level 2 will be dissected properly, but there are some times where you do not see any surgical changes in the level 2. In that case, we have to follow what Dr. Beriwal has said. It is supraclavicular, that is level 3, level 4, and undissected axilla has to be included if at all the regional nodes have to be drawn. So undissected axilla, identifying the surgical changes is very important. If the surgical changes are not there, then it means the surgeon has not dissected level 2, and then you have to include level 2 also in your volume. So in clinical practice, we do it very simple. We don't we don't routinely separate them as level 1, level 2, level 3 and all. What we do is we draw the supraclavicular volume, that is level 4 volume, separately, and then level 3 and whatever the undissected axilla is there, that will also be included as the nodal volume. So one simple volume, I can see here, there is no surgical change, which is obviously seen here. So I have included it as an undissected volume here. Then let me finish off this level 1. Level 1, as I told you again, it is 0.5 centimeters above the subclavian vein, and inferiorly, we need to go up to the 4th rib. Or if the sentinel node biopsy changes are seen, we have to include those changes also in the level 1 nodes. The mouse is not moving fast. Yeah. So then posteriorly, it has to be the ribs and intercostal spaces. And laterally, there is some problem with the mouse. Huh? Okay, fine, whatever it is, we have come to end of it. So this is the latissimus dorsi muscle, and we have to be drawing a straight line along the latissimus dorsi muscle. We don't go up to the latissimus dorsi, but this forms the end of the lateral, what you call the lateral border for the level 1 node. So we have finished all the level, regional nodes. We have done the IMN nodes, level 4, level 3, level 2, and level 1. So always start, this is more convenient for me. This is how I have been doing. I start with seeing what is the lower border for the IMN, identify the 4th rib, then go superiorly, form the 5, that whatever the lower border for the supraclavicular field, that is level 4 field is there, identify that, then mark all the IMN nodes in that area, then go to the supraclavicular field. Supraclavicular, just for my convenience, I am drawing only, I take the superior border up to the lower border of the cricoid cartilage, because I'm always scared about this nodal recurrences in this area. But for early stage disease, you are fine if you can stop with 5 millimeters above the subclavian vein. Then level 3, again, it is 5 millimeters above and below the subclavian vein. Level 2 will be between the pec minor muscle, and then level 1. So this is how we do. And for the sake of completion, let me finish off. Dr. Beriwal has already told us how to draw the chest wall. So it is important to identify the intercostal muscles and the ribs. Always, this is a clinical planning. So it is not just based on what we see on the CT scans. You have to put a marker when we do the simulation. So what we do is we keep a middle marker, at the mid axillary line, and then whatever the breast tissue we see on the medial side also, we do that. And then take everything. We also include the pec major and pec minor muscles also in the volume. So I think I've done the chest wall also. Yeah. So this is how we include. We include the pec major and pec minor muscle. So this is one area where ISRO recommends that it has to be 5 millimeters below the skin, until unless you have a T4 disease where you have to include the entire chest wall along with bolus. But rest of the cases you can crop at least 5 millimeters because skin is not required in T1, T2 chest wall lesions. But T4 lesion, definitely you have to go up to the skin and also with the bolus. For BCS cases, you have already the cases for you, where you have to identify what is the vessel called the medial perforating vessel. So that is something, yeah, maybe I can show it to you on the opposite normal breast. Sorry. Suppose we are contouring the intact breast. We have to identify the medial perforating vessels. Let me show you here. It might not be clearly visible on all the sections. This is the vessel here. So we need to be lateral to the vessel. So this is a vessel which arises from the internal thoracic artery, and this vessel supplies all the breast tissues. So we need to be lateral to this medial perforating vessel. And laterally, we also need to identify the lateral thoracic vessel. This is the lateral thoracic vessel, and be sure to be above this lateral thoracic vessel. But sometimes because of anatomical variations, the best thing is to mark the intact breast with a wire, which we routinely do in our clinical practice. We keep a marker on the medial side, the lateral side, and superiorly, we do not go beyond the sternoclavicular joint. So this is how we do it. And inferiorly, of course, it should be just where the breast tissue is finished, or routinely what we say 2 centimeters below the opposite breast. And when we do the intact breast radiation, we have to exclude the muscles. It is not required to include the pec major and pec minor muscle there. Your contour should start from here. Your contour should be starting from here. Do not include the pec major or pec minor muscle. Okay. So for this reason, I felt like Deepak is there. Can someone call Deepak? We are done with the. If I have to answer any questions, I can still answer. मैसेज आया है? For level 4 lateral border should be crossed beyond the sternocleidomastoid muscle. So let's go to the level 4 nodes. This is the level 4 node. And the lateral border is, this is the medial border. This should include the trachea and the thyroid muscle. Lateral border is somewhere at the junction of the subclavian vein and the internal jugular vein. So this is the internal jugular vein, and this is the junction. and it should not cross beyond it. But if you have the scalene muscle there, it has to be included. Yeah. So maybe you can open up the cases which have been presented to you. Any case, whichever is your choice. Maybe if you want to go ahead with the post-mastectomy case, it is case number 14. Case number 14, where you can practice all the regional nodes. Next 15 minutes or so, any case of your choice, but I prefer to do this one, case number 14. 14. Patient number 4. Open up patient number 4. That's a left-sided post-mastectomy case. You can draw all the regional nodes, that is IMN2 level 1 nodes, and also the chest wall. Then we can pull up each one's contours here, and then we can discuss what are all the sections which have to be done. Yes, I think for the online people, there is some technical issue. We cannot display those other cases. For online, what else is there? I've done. I'm done. Second law.
No, we have one physics session remaining. Presentation by Dr. Suresh Chaudhary. You please stay back for 3 or 4 minutes. We can call.
So what I'll do is now Dr. Suresh will come up and there are some questions in the chat box. No. Yeah, Dr. Beriwal says we can consider in high nodal burden cases also.
Good evening, everyone. I am Suresh Chaudhary. I am the Chief Medical Officer for American Oncology Institute. So now we will discuss the planning and dosimetry in the breast cancer. So already in the previous session, Dr. Beriwal has spoken a lot about the planning and the dosimetry aspects of the breast and even the OR constraint. So now my job is easier that I just have to run through some of the slides. And with respect of time, I will try to limit my presentation as much as possible.
For the students here, can you please concentrate on this talk, because planning is very important here to understand what do we do. And after that, we can continue with the contouring. I will do it after.
Yeah. So as in radiation oncologist and medical physicist, we all know that the planning objective is that we need to have an adequate coverage to the target volume, and the dose has to be as uniform as possible. And of course, we will have to minimize the doses to the normal tissue. So the normal tissues, whichever are defined, other than whatever is available, so that will be called as a rest volume of Paris. And for those volumes also, we'll need to minimize the doses. Since we have spoken about the dose prescription and the OAR doses and a bit of the planning aspect, so what I will do is that we will try to focus on much on the immobilization and the simulation aspects. So workflow of the department is that we first immobilize the patient, then we do a CT scan, and if a MRI is required, then a previous MRI which is fused with the CT, and then we delineate the volume and a treatment planning is done. And before the treatment plan is delivered on the patient, there has to be a mandatory QA. So let us discuss something about the setup of an immobilization. So we all know that the primary goal of our simulation is that we have to minimize the setup error. As the patient will be treated over the number of fractions, so we will expect that the patient position remains as in the first CT scan. So in the case of breast, there are two types of simulation we do. Predominantly, all the breast cases, we try to do it in a supine position. But there can be a special cases where some of the institute also use prone position. So in the case of breast, since it is a mobile organ, it should be easily reproducible. So we use almost three type of devices. One is the breast board. So the picture over here, you will see that it is a breast board and it has a different inclination angles from 5 degree, 10 degree, 15 degree, 20 degree. Okay, so second is the backlog and third is the essential component is the wing board. So a breast board, the advantage of breast board is that it has the device is suitable with positioning of arm, wrist, head, and shoulder. So we all know that when the patient is lying on the breast board, the arms will be in the position so that they should not interfere in the tangential beam arrangement. One of the disadvantages of the breastboard is that in the newer machines like a TrueBeam and Elekta, where the laser guide is available, we cannot give an angle more than 10 degree. Okay, so but what in the literature and our own experience is that more than 10 degree inclination for the breast cases is not required as we are using IMRT and VMAT technique. So these breastboard are made up of a carbon fiber so that there is minimal attenuation of the radiation beam. So another is the special case where we use the prone breastboard. Now this breastboard is a completely different where the patient will be lying in the prone position. So for the large breast cases, this is a suitable technique. The only limitation of this type of breastboard is that since the patient is lying in the prone position, the setup is difficult. So this is the one slide, since as I said that the setup in the prone case is difficult, but if you see the dosimetric advantage, on the left side is the prone position and on the right side is the supine position for the same patient. You will see that in the prone case, maximum, in fact, you will see that the lung and heart doses are negligible. But if you see at the right side where the position is the supine, some part of the lung is irradiated and some part of the heart is receiving a dose which is more than in the prone case. So we have to define judiciously whether we are going to use a prone or a supine board. But prone, as I say, that when the breast size is larger, in those cases, we will be using this. This is the wing board. So with this, we can use the backlog, and the wing board has the handles where patient can hold those handles so that the setup is reproducible. In the case of simulation, we will do a standard simulation with 3 mm of slice thickness, and scar and the drain sites will be identified with the wires. And the the breast will be marked with the radio opaque wire so that will be visible on a CT scan, and that becomes our margin in the superior, inferior, and the lateral direction. So we have already discussed this. Arms are elevated, abducted, and rotated to facilitate the tangential beams. So predominantly, we will be using three techniques. One is 3D CRT, IMRT, or VMAT. So in the recent years, there is the advancement in IMRT and VMAT technique, and many people are preferring this type of techniques over 3D CRT. So this is a simple example of a 3D CRT where the tangential beams are used. The advantage of 3D CRT is that the lung volume, if you want to use this beams, there will be some part of lung will be irradiated. Second thing is that the heart also can be irradiated. Dr. Beriwal already spoke about DIBS technique, where the patient hold the breath in deep inhale mode, so that the distance between the target and heart increases, and we can easily avoid the radiation dose to the target. The suitable beam, since most of the accelerators will have a 6 MV beam, so we will go for a 6 MV beam. Very rarely we use 10 MV beam and 15 MV beam. As you know that the surface dose decreases as the energy increases. So we should go for a lower energy beam. So this is a picture for the same patient. The important aspect as a physicist, what we do is that you will see that in the medial border, the divergence of the beam in the left side. So when the beam is diverging, that means it is going to expose a part of lung. Okay. So the same divergence we have corrected in the right side of the picture. So what we have done is that one of the beams has been rotated by 5 degrees so that the beam edges are matched. Now, when the beam edges are matched, so since now there is no divergence of the beam, so the low doses to the lung will be reduced. Another technique, what we use is that we use the half beam block. Now, what is a half beam block? So in the half beam block, what we do is that one of the jaws are completely blocked. That means at the isocenter, half the beam is blocked with one of the asymmetric jaw and half the beam is open. Now the advantage of this type of geometry is that in the medial border, you see that there is no divergence at all. So the low doses due to penumbra and due to scatter, there will be no low doses. Now in this case, the isocenter will not be in the target area, but it will be away from the target area because we have blocked the beam in halfway. So you will see that the placement of the isocenter. Now, when we are using these tangential beams, since in the case of breast, there is a curvature. So there is an air gap which has to be compensated. So you will see that on the apex of the breast, there will be a lot of penetration of the radiation beam. As we go towards the lung, there will be a lot of attenuation because the tissue in the beam path is increasing. So we will have to correct for this inhomogeneity. So one of the techniques what we used to do is that on the left side, you will see that it is a case of half beam block and that is the radiation isodose. So on the surface, you will see that there are 3 lines. One of the isodose line is the hotspot. So since there is a lot of transmission of the beam because of the loss of tissue, so you will see that at the level of skin there you will see a lot of hotspot. Now this hotspot can be reduced with the help of wedges. So on the right side you will see that we have used 2 wedges. So the thick part of the wedge will compensate the loss in the tissue and it will compensate for the transmission and we will get a homogeneous dose. So generally we will use a wedge of 10 degree or 15 degree or maximum 30 degree. Very rare cases people use 45 degree, because as we tend to use more than 30 degree, the hotspot will be shifted to a medial direction. So rather than compensating the transmission at the due to loss of tissue, we will be adding more hotspot in the medial direction. So the wedge has to be chosen in such a way that you get a uniform dose. So there are two types of wedges are available. One is the hard wedge, okay, and another is the dynamic wedge. Now, since we have already moved to era of IMRT and 3D VMAT, people still use this technique, but they do not use the hard wedges, because due to hard wedges, there is a lot of scatter which goes to the medial breast and the heart. So we use the dynamic wedge, which is one of the jaws in the machine moves and it takes the shape of wedge. Another technique in 3D CRT, I saw that Dr. Beriwal has some pictures about this field in field technique. So this field in field technique is we used to call as a forward planning, where we don't use wedge or we don't use IMRT or VMAT, but we try to reduce the hotspot, or the cold spots will be compensated in such a way that we will use small beamlets. So when we use IMRT, the algorithm calculates the beam aperture shape. But in the forward planning technique, we as a planner will calculate the shape of the beam. And the advantage of this field and field technique is that it will have less number of monitor units compared to a IMRT. When people use only the radiopaque marker for the delineation of the breast, so in those cases, we will have to look for this central lung distance and maximum heart distance from the beam edges. The importance is that you see the radiation remunerating risk is increases as central lung distance is more than 3 centimeter. And as we go beyond 3 centimeter, the pneumonitis risk increases. So in the tangential beam arrangement, the beam has to be limited in such that minimum distance of the lung is in the field and the minimum heart is in the beam. So one of the techniques, as I already said, that deep inspiration breath hold, where the distance between the target and the heart will be increased. Another important aspect is that the contralateral breast dose, which should be reduced as much as possible, where we use the ALARA principle. So we try to see that the breast dose is less than 1 or 1.5 gray for the whole treatment. Dose of the radiation, we have already talked about this. So these are the clinical goals which we use. There is a clinical goal for a PTV heart. Since Dr. Beriwal has already spoken about what is the rationale for this clinical goal, so we can skip this slide. So with this tangential beam techniques, there will be a lymphatic radiation. So a simple anterior portal is put for this supraclav field with 10 to 15 degree in separate angle for a laterality to save the spine. One important is that since we will be using the tangential beam and the supraclavicular field, so the junction of both has to be matched in such a way that there is no overdose or underdose. So this is the one of the examples where we have used 2 tangential beam and 1 supraclav field, and you will see that the junction is matched such a way that there is no overdose in the junction area. So the advantage of 3D CRT planning is that the plan is simple, the complexity is less. Monitor units are less. The importance of less monitor units is that when we use this DIBS technique, the patient has to hold the breath. And if we are treating for a 15 fractions, all 15 fractions, he will have to hold the breath in such a way that the So as the days pass by, the patient won't be able to hold the breath as it was in the first fraction. So if the monitor units are less, then the treatment time can be reduced and the patient comfort is also good. So now we are coming to the IMRT where again we take the use of the tangential beams. So you will see that always in IMRT also we try to see that the beam should not go beyond the tangential edges of the PTV so that the hard and learned doses are as minimal as possible. So people tend to put beam from the posterior direction, but one of the principle of IMRT is that it will optimize, but it should be ensured that the normal tissue should not be in the beam path so that the optimization also is simple and the monitor units are also less. So generally we will be using 3 to 5 beams depending on the institutional preference. Now, when we are using IMRT in 3D CRT, we always give a flash field of 2 centimeter. But in case of IMRT, there is no flash. So flash is to compensate the superior edge of breast and the beam. So in IMRT, we will have to manually add the flash. So when we do a IMRT plan as a radiation oncologist, you also you should also see that the flash is added or not, because that is an important aspect. Of physicists may forget, but there has to be always a second check from the radiation oncologist. So this is one of the examples of an IMRT plan where the tangential geometry is still maintained, but the lung and heart doses are less. So there are again advantage and disadvantage. As I said, the monitor units are more. So when you are giving a DIBH, it may not be possible that the patient will comply, as she may not be hold the breath for a longer time. So that disadvantage of the monitor units has been now compensated by the VMAT technique. Again, in the VMAT technique, again you will see that the beam geometry is such that my field edges are still matching with the tangential, like a tangential 3D CRT arrangement. So the part of the lung and part of the heart is not at all in the beam path. So the advantage of the VMAT technique is that there is a better homogeneity and the conformity. We can do a OR sparing. Treatment time is less. Monitor units are high compared to a 3D CRT plan, but less than an IMRT plan. So in case of BABS, that will be an advantage, yes. But still, there is still debate going on whether we should use IMRT or VMAT. But we have to decide as per the patient compliance, OR doses, and the conformity, whether we should go for a VMAT technique or IMRT. Thank you very much.
Thank you, sir, for such a nice presentation. And now I think ma'am can supervise the students. And so I request Mr. Rehan Hussaini for vote of thanks. And we are thankful to people who have joined us online. We will continue with our postgraduates and senior residents here for contouring, but our session is going to close now. I request Rehan Hussaini sir to please say vote of.
Would like to give a big thanks to the team and whosoever have participated here. President Dr. Neeraj Jain, a special thank to him, and the participants, and especially Dr. Deepa Gabrol and Dr. Satyankar, who have put in their lot of hard who have put in their lot of hard work into it to make it a great success. Wish you all the best, sir. Wish you all the best. And thank you, everyone. Dr. Thank you very much, Dr. Neeraj. Thank you, everyone.
At 7 at Royal Park, but students can continue here till 7. Actually, we can close.